Thank you for the invite to the World Congress of Anaesthesiologists. It gives me great pleasure to talk about a topic that's so pertinent for many of us around the world as we are challenged with these surgical backlogs. How do we ensure the right patient gets the right surgery? How do we choose wisely? For those of you who don't know me, my name is Dr. Ramai Santhirapala. I'm a consultant anaesthesiologist based in London, and I'm also the clinical lead for Choosing Wisely UK. So for those of you who don't know where Guy's and St Thomas's is, my provider, we're fairly conspicuous in London. St Thomas's is right by the London Eye and Guy's is right by the Shard. Perhaps more interestingly, we see a lot of complex patients undergoing complex surgeries. We cover most surgical specialties with the exception of hepatobiliary and neurosurgery. And we're also tertiary and quaternary, so specialist referral centres for many surgical subtypes. It means we have multiple conversations about the complexity of matching the right patient to the right surgery. So you've heard a bit about my professional background, but actually who am I? So I was born in Sri Lanka, I started school in Nigeria, and I'm now based in London. I have a huge international close-knit family. Why am I telling you this? Because it affects the lens through which I see life. It affects my values, my preferences, and I'll give you an example. I have the great fortune outside the pandemic to enjoy waterfall hikes. I'm Sri Lankan, so multiple waterfalls in Sri Lanka, obviously, but I also have the misfortune of family in Hawaii. The photo that you see to your left is Pali High Falls in Oahu, Hawaii. Beautiful waterfall hike if you're ever in that part of the world. Obviously, the pandemic limited that to some extent, and I ended up in Tresaith in West Wales, also on a waterfall hike, but it had a very different outcome. So as you can see, I sustained a fracture, an avulsion fracture, in my left dominant hand. I went to the first provider, a plastic surgeon, and they said, you absolutely need surgery. We're going to list you on a trauma list in 48 hours. Can you please sign the consent form? Now, they were really generous with their information and time, but I just didn't feel that I could make that decision there and then. I was surprised that I had a fracture. I was still trying to come to terms with that. I was trying to understand my options and I was trying to make an informed choice. So I asked for a pause and I said, how long have I got? And they said, well, up to 10 days. I'm in a privileged position being a healthcare professional to be able to get a rapid second opinion. And I got another plastic surgeon who said, actually, surgery is the worst thing you can do. It's adding insult to injury. I would advise intensive physiotherapy. Of course, there was always the option of just letting nature take its course and do nothing. Now, what became really apparent to me is one provider was treating my x-ray. I had bone on cartilage, which supports kind of non-union or non-healing. And I would never have the perfect x-ray. Surgery would try and give me that perfect x-ray. However, provider 2 is probably thinking much more about my functional outcomes and what I'd be able to do with that hand once I'd healed. Now, as you know, I'm an anaesthesiologist and the laryngoscope is a left-handed instrument. I'm also very left-handed in most aspects. I do a lot of yoga, and for those of you who do yoga, you'll know that you put a huge amount of weight through your hands. I also play a South Indian Carnatic instrument called the veena. So I wanted to get back to doing the things that I enjoy. I was more interested in my functional outcome. So this question of to operate or not is something that we ask increasingly as anaesthesiologists alongside relevant colleagues such as our surgeons. And I was lucky enough to publish or co-author this review article alongside a geriatrician and surgical colleague. And here we really talk about the science of decision-making, so risk assessment, risk stratification, risk optimization, particularly pertinent in this era of prehabilitation, but also the slightly softer skills that we need to have with our patients, to have those vulnerable, open, transparent conversations, to what's known as shared decision-making, unlock the patient. So we talk about that quite transparently as well. So I hope we've achieved quite a nice balance. And just to really, drill home the concept of shared decision-making, which is the central tenet of Choosing Wisely UK. So unlike any other of the international initiatives, and thankfully well received, Shared decision making is really taking professional expertise and opinion, but also centering those decisions on what's important to patients, so their values. So it's neither paternalism, it's not doctor knows best, but it's taking the best of the kind of expertise, and neither is it give the patient everything they want. It's actually saying, let's have some valid options, and through that we'll discuss how we center these decisions on their values and preferences. So how do we center the right option on what's important to the patient? So Choosing Wisely UK, really lucky to be part of a great international community. We're one of the 22 countries that have launched. We launched back in 2016, and I was lucky enough to be part of that launch and now national clinical lead. And we really center our efforts on the acronym BRAND, so benefits, risks, alternatives, and doing nothing. And this is a BJA editorial for those of you interested in knowing more background. And this came from the patient representatives on our national steering group. And they said, we want something really simple to be the central tenet of the initiative, something that's easy to remember, but something that's also really relevant and touches on all aspects of the conversation that you should be having with healthcare professionals. We developed national recommendations, much like all the other programs, so no particular difference there, in the sense that we asked for 5 recommendations from each specialist society and royal colleges, as they're known in the UK. But actually the difference for us was that we really asked for those recommendations centered on shared decision making. So think about preference sensitive decisions, or where there's some grey, and let's center those recommendations on them. Of course, some of them are the more historical do not do's that Choosing Wisely is more known for. We, when we actually implemented the recommendations, which is, I think, the more interesting aspect, we asked for executive buy-in, so CEO buy-in at each provider that we launched within. This is an example of the governance structure that we had at my hospital, Guy's and St Thomas's. So we had executive lead, we had trust lead, which was myself in this case, and we put out for pilots who would want to support Choosing Wisely UK. Huge amount of enthusiasm. We selected 3. We thought that was pragmatic for the first kind of run. So the knee orthopedic pathway, the perioperative medicine for older surgical patients, and also our dermatology skin cancer service. We underpin this with a patient information and a staff facing campaign, which I'll go on to. And we ensured that we identified external stakeholders, so NHS England, which is our provider, our national provider that regulates all hospitals and all healthcare. We obviously interlinked with the Academy of Medical Royal Colleges, which in the UK leads on Choosing Wisely UK. The first thing we wanted to do was ascertain the baseline. I think with any new innovation, you want to really try and articulate, the state of play before any intervention. Number of tools that we could do to use this, and shared decision-making measurement is almost a talk in itself. But in short, there's subjective and there's objective tools. The subjective tools are perhaps less sensitive, and I'll come on to that in a second. And the objective tools are labour-intensive and cost-intensive, and perhaps not pragmatic outside a research trial. We went with the SDMQ9, which is a 9-pointed questionnaire. 9 aspects of shared decision-making are measured, and it's a paired questionnaire where the patient gets a copy and the individual, the healthcare professional involved, gets a separate copy, and they independently fill them out. And it asks for each, either the healthcare professional and the patient, to essentially rate the 9 aspects of shared decision-making on a 6-point Likert scale from completely agree to completely disagree. The scores in our pilots at Guy's and St Thomas's, across all 3 pilots, now the blue bar represents the patient responses and the grey, the healthcare professional responses, is that, at first glance, it could seem that we already do shared decision-making in the eyes of the clinicians and the patients, but actually we wanted to get more granular than that. And really what came through this is the SDMQ9 measures patient confidence, clinician confidence. So how confident are our clinicians that they deliver shared decision-making? We know that that's generally overplayed, and that's certainly supported by the literature. Clinicians think that they do it already. And on the flip side, it probably measures patient satisfaction, so their kind of satisfaction with the whole care rather than nuances of the quality of the shared decision-making per se. So perhaps not the best tool, and it seems to have a relatively high ceiling effect. The other aspect is that we process map pathways. Now, all of us as anaesthesiologists working in the preoperative sphere or in high-risk clinics will understand that slight challenge of often getting patients very close to their date of surgery and not feeling that they're informed perhaps as robustly as we would have hoped that they would be. And you're almost starting that shared decision-making process very late in the pathway. Now, through process mapping, we can actually come to realize why that's the case. And one aspect is that, for example, our orthopedic vetting process needs to be more robust so that actually our orthopedic surgeons were seeing appropriate patients. The other aspect was that, just the flow through X-ray was delaying a lot of appointments for our orthopedic surgeons, so their consultation times with patients was shortened. So we looked at aspects such as training our physiotherapists in supporting benefits, risks, alternatives, and doing nothing conversations, and not so much the detail, but empowering patients that these are the kind of conversations that we're having at Guy's and St Thomas's, and they are active participants, and that seemed to improve the kind of onset or the timeliness of shared decision making. The other aspect we did stakeholder engagement, really important in any new innovation that you get both your proponents, but also those people who would challenge you into a room. We had, surgeons, we had anaesthetists, we had physicians, we had pathway navigators, physiotherapists, nurses, administrative staff, management. And some of the themes that came out through those focus groups was that there needs to be a standardized patient information, and agreeing that common language. For us, it's BRAN, but it may be different for you. That actually, as clinicians, we do feel that pressure of external targets, and we have the 18-week target, for example, in the UK, and that can limit our kind of bandwidth for having these more elaborate conversations. And greater expectation management and prepping was needed in patients prior to their arrival to their first kind of healthcare professional appointment. Similarly, on the flip side, we did 57 semi-structured interviews, and again centered on BRAN, and again, supported by patients, which was, not unexpected, because we did a huge amount of engagement at the national level when we supported this acronym. But our patients were telling us that actually we really believe in shared decision making, but it'd be really great if the healthcare professional can initiate those discussions, because we still don't feel empowered to have them, which is interesting, I think. We need information leaflets around the appointment and information ahead of time. But however much information you give us ahead of time, please can we have prompts on the day, because we still feel that anxiety or that worry on the day of seeing a healthcare professional. On the back of that, we developed these leaflets, and these are on the Choosing Wisely UK website. And it's really to encourage patients, so they're sent ahead of appointments to actually discuss BRAN, so what the benefits, risks, alternatives, and doing nothing from their viewpoint, from their understanding, but also try and elicit their values, hopefully in the calmness of their home before, the anxiety of a healthcare consultation. We've done education and training a huge amount. In fact, we've just won the King's Health Partners Awards for these workshops. These are centered around perioperative shared decision-making, and we have a plenary speaker, video component, and role play. And we've had some excellent speakers. We've had Nadine Montgomery, who's a claimant in a major UK legal case that shifted UK law towards more transparent conversations. And we've also had Angela Bader, who's come across from Harvard Medical School. What these workshops have shown us is that there's an increase in confidence in the participants, and this is data from close to kind of 72 participants. But more interestingly, in the qualitative information that we're collating is that the healthcare professionals who attend have this light bulb moment. So they suddenly go from thinking they do it already to thinking, gosh, there is a gap between ideal practice and my practice, and how can I improve that? And these across the board. So surgeons, anaesthesiologists, physicians, nursing staff, physiotherapists, for example. We support these with e-learning, and this is a 2-hour module. It's internationally available. It's open access, so anyone can create a login. And we've had excellent feedback from this, just in the kind of granular detail of trying to understand shared decision-making in, what I hope is quite a pleasurable experience. But it's interesting because when we've done the initial analysis in the first 400 participants, we found that actually clinicians kind of sometimes struggle with their numerical skills, which is obviously the underpinning of risk. So if clinicians don't really understand risk, it's really interesting what we relate to patients and patients' understanding of risk. I just want to close by highlighting some resources that we've put together under the HATF Centre of Perioperative Care, so particularly shared decision-making for the perioperative sphere. These include Choosing Wisely UK, but also other national initiatives. And with that, I'll close. Thank you very much for listening.